Welcome to this session, which is going to focus on severe forms of insulin resistance, both congenital and acquired. My name is Robert Semple. I'm based at the University of Edinburgh, and for at least 20 years now, my focus has been on mechanistic studies and clinical management of a variety of different forms of extreme insulin resistance. Now, I should say that I'll make one or two observations as we go through about lipodystrophy, but I'm very conscious of the excellent presentation by Professor Ceccherini from Pisa, which is part of this series, and I commend that to you. And so shall only make one or two observations to contrast lipodystrophy with the disorders which I'm going to talk about. So we're going to, first of all, think in fairly general terms about insulin resistance, because it seems to be a simple concept, but it's one which we can sometimes be too simplistic about. So this is just a reminder that although we're all very used to type 1 diabetes these days, it's very rare that we see type 1 diabetes in its full untreated form. But now that we approach the centenary of the discovery of insulin, I think it's timely just to remind ourselves that this is what complete insulin deficiency looks like. So complete insulin deficiency is a cachectic, horrible wasting condition which leads to early demise and which is dramatically restored in the short term by insulin. And that's why the Nobel Prize followed so quickly after the discovery of insulin for Banting and MacLeod and Collett. But the history of insulin resistance really started after that. In the first 10 years or so of insulin, it became clear that not everybody was as apparently cured as those first emaciated patients who were treated. And in particular, through the work of Harold Himsworth in the UK in the 1930s, it became clear that a proportion of people with diabetes, when infused with both glucose and insulin, as you can see in the upper figure here, actually failed to respond to insulin. In other words, if they were given glucose alone, they became hyperglycemic, and insulin failed to make a major difference to this, which was quite distinct from the patients who still mounted a marked hypoglycemic response to insulin. And that's where the concept of insulin insensitivity or insulin resistance was born. But it was really quite a slow development of the concept, essentially because of our inability to assay insulin quickly in the plasma, which only arrived with the Nobel Prize winning work of Rosiello and Solomon Berson in the 1960s. And as soon as it became possible to measure insulin in the plasma, it became clear that indeed this insulin insensitive form of diabetes, which we've come to know as type 2 diabetes, did feature, at least in its early stages, high levels of insulin in keeping with insulin resistance. And this is just a couple of panels to illustrate the close relationship between body weight, shown as body weight here, or body mass index on the right, and immunoreactive insulin in the plasma. This is one of the earliest studies showing that as body weight increases, so plasma insulin goes up. And this is much more comprehensive data in the modern era, taken from the eastern region of England from 800 people, showing the 50th centile for insulin levels, the 95th centile, and the 5th centile. And so you get the sense that as body mass index increases, some people do fairly well, but a large proportion of the population develop a very high insulin level consistent with insulin resistance. So there was a growing concept that insulin resistance in itself is an important phenomenon. One of the challenges with thinking about insulin resistance is that it can mean different things to different people. And that is in part because insulin is a complicated hormone which does many, many things to cells and tissues. So as somebody who's worked for many years on clinical severe insulin resistance, I often think in terms of shorthand, in terms of the clinical syndromes that we see, where I think in terms of polycystic ovary syndrome, hyperandrogenism, acanthosis nigricans, fatty liver, and such like in different combinations. So that is, if you like, the clinical syndrome of severe insulin resistance. But that's no good for measuring and quantifying and defining insulin resistance. And so in general, that is done in terms of the ability of insulin to lower blood glucose. So quite simply, the purest definition is relates to the degree of blood glucose lowering when insulin is administered, much as I showed from those early studies of Harold Himsworth. However, even that is very complicated in practice because most patients with severe insulin resistance have some degree of beta cell decompensation, and consequently they have a mix of endogenous insulin, hyperglycemia, and often exogenous insulin as well. And so it actually becomes very difficult to rigorously define severe insulin resistance. We can do that in clinical practice in those who make no insulin, those with complete insulin deficiency. And we can do that in terms of their daily insulin requirement. And we sometimes say that more than 3 units per kilogram per day is an arbitrary distinction. But it's much more difficult in those other patients who have partial beta cell decompensation when we have to take that into account. There's also a large population of more mechanistic people who study the effect of insulin on cells and measure the different response pathways downstream from insulin. And in principle, insulin resistance can be defined in terms of the response of any one of those pathways to insulin. So insulin resistance is generally simply taken to mean reduced ability of insulin to lower blood glucose, but it could be many things, and sometimes is regarded as many things by different investigators. So a few general observations before we start. So insulin resistance is obviously not the same as diabetes. And in fact, for many people before diabetes develops, they are still very likely to present to clinicians, but often not to diabetologists. Rather, the places to look for severe forms of insulin resistance might be first in an endocrine clinic, a gynecology clinic, a dermatology clinic, a lipid clinic, or a hepatology clinic, or indeed an acute surgical take for patients with lipodystrophy, for example, who come in with pancreatitis. The culture of diabetology, moreover, means that insulin is actually very rarely measured. And so unlike the rest of endocrinology, we have less access to the objective measures of insulin resistance. And of course, as obesity becomes more and more common, so severe insulin resistance becomes more and more common. And that makes picking out the people with the single gene severe forms of insulin resistance ever more difficult. I think it's fair to say that we don't exactly know the prevalence of severe forms of insulin resistance. I think it is, based on my years of study, probably significantly rarer than MODY, but because it is underdiagnosed, it's not possible to be completely clear. All these observations mean that there is a major role for clinicians in diagnosing and treating insulin resistance, and I think that is very encouraging for those of us who try to make a career out of this. So what I'm going to talk about mostly today are the monogenic, or the acquired antibody forms of severe insulin resistance. And this is just to put those in the context of the history of insulin since the discovery of insulin by Banting and Best. And you can see that essentially nearly all the forms of severe insulin resistance have been discovered this century, with the exception of defects in the insulin receptor itself. So we're talking about a fairly recent discovery of a plethora and a growing plethora of different forms of insulin resistance. So I'm going to talk first about some of the clinical features of insulin resistance, some of which might be quite obvious, but I think some of which is interesting and also tells us things about common forms of insulin resistance associated with obesity. As I said, we relatively rarely measure insulin concentrations, and so the clinical sign of acanthosis nigricans is incredibly valuable in clinic in picking up severely insulin resistant patients. It's really a very benign hyperproliferation of skin cells, which pushes the skin into these folds. It occurs classically in any flexures, such as the neck, under the arms, in severe cases in other skin folds, such as the groin. And although even in the 1990s, I was taught about it as a paraneoplastic manifestation of some cancers, in the overwhelming majority of cases, it denotes insulin resistance and is much quicker and simpler than finding a frozen plasma sample to send off to the lab. Now, it's not a perfect marker of insulin resistance because occasionally people have rare forms of acanthosis which aren't caused by insulin resistance, and also how severely the acanthosis develops depends on skin color and skin type as well. It can be very distressing. It's quite common for adults with insulin resistance to recall their mothers trying to scrub their neck to get rid of what they think of as the dirt around the neck. The thickening and the brownness of the acanthosis commonly is associated with skin tags or acrocordons, which you can see very dramatically in B. And in the most extreme examples, rather than just being in flexures, acanthosis can eventually affect flat areas of skin. Acanthosis requires the presence of high levels of insulin, and so as insulin resistance decompensates and diabetes becomes poorly controlled, so acanthosis gradually fades. So there can be good reasons for acanthosis fading, but it can also be sinister. And I think it's interesting that it's not the only overgrowth feature of insulin resistance that is seen. So it's certainly true that not all polycystic ovary syndrome is caused by insulin resistance, but I believe it is true that most polycystic ovary syndrome is driven by insulin resistance. We know that insulin resistance alone is enough to do this as long as gonadotropin secretion is intact, because we see this across all the known forms of severe insulin resistance. And in the most dramatic cases, in acquired forms of severe insulin resistance, ovaries acutely enlarge, develop a polycystic morphology, and then regress after treatment of the acquired insulin resistance. So numerous lines of evidence tell us how important the ovary is as an indicator of insulin resistance. And ovarian dysfunction is one of the major reasons for the preponderance of women among those who present first with insulin resistance. So you can see some of the luteinized stroma, hyperthecosis, cysts, both in the ultrasound scan here and histologically. And you can appreciate how enormous these can sometimes be. And these are all images taken from people with single gene forms of insulin resistance of different types. And I never fail to point out to people how severe the resulting hyperandrogenemia can be. And in work together with the NIH group, we have collated all our testosterone data from the last 20 or 30 years. And you can appreciate that testosterone levels can grossly exceed the upper female limit of normal, and indeed, not uncommonly, can exceed the male limit of normal. In SI terms, our peak testosterone level in this graph is up to 54 nanomoles per liter. So it is not at all uncommon for severe insulin resistance on its own to produce the sorts of testosterone levels which normally make us worry about androgen secreting tumors. This does require an intact gonadotropin axis, and in fact, in those patients who receive GnRH agonists to suppress gonadotropins, their testosterone too can be dramatically suppressed, even if the insulin resistance persists, demonstrating that this effect of insulin on the ovary requires both gonadotropins and insulin. So to move on to other forms of overgrowth associated with insulin resistance, this is a case report from Australia, which represents a subset of the patients we see who develop accelerated linear growth in childhood, although this often doesn't translate into excessive adult height due to an accelerated trajectory of puberty as well. We don't know the molecular etiology in these cases, but this is not uncommonly seen in genetic forms of insulin resistance. And the corresponding adult abnormality, as you might expect, is pseudoacromegaly. Again, a very common feature of essentially all the forms of severe insulin resistance I know. This man has a mutation in PPAR gamma, the TZD responsive gene, and you can see his prognathism and spade-shaped hands. This is a phenomenon which may be seen across lipodystrophic and non-lipodystrophic forms of insulin resistance. So I point these things out first to emphasize that this is very different to the picture I showed you of insulin deficiency. So pure insulin deficiency is a purely catabolic state and features wasting away of soft tissue. Whereas actually insulin resistance features a mixture of, for example, hyperglycemia when it decompensates and other expected features, together with overgrowth features in the whole body or in particular tissues. And this isn't tremendously well understood, but I think it's true to say it must reflect the complex interactions between the insulin and the IGF-1 signaling systems, which potentially occur at multiple levels of the growth axis. And it makes the point that the syndromes that we call insulin resistance are not the same as insulin deficiency. They are a mixture of insulin deficiency and insulin excess, which is still able to act via intact pathways, possibly involving the IGF-1 receptor. A couple of other brief points just before we move to specific types. I'd make the point that hypoglycemia is actually not an uncommon feature in the early stages of severe insulin resistance. And this is attested to by scattered case reports over the years from us and others. And we have not uncommonly seen that in our patients with the most severe forms of insulin resistance. And the hypoglycemia is always associated with extremely high insulin levels. It may be fasting, but in particular, it's postprandial and sometimes responds well to reducing the glycemic excursion with agents such as acrobose. And it repeatedly catches those out who work with congenital hyperinsulinism, as sometimes very high levels of insulin with insulin resistance are associated with episodic hypoglycemia. So that's one to watch out for. This tends to get better as decompensation into diabetes occurs, as you might expect. This is an Italian case from Fabrizio Barbetti's group, just illustrating on the CGMS prolonged periods of hypoglycemia overnight in a child with biallelic insulin receptor mutations. Okay, so those are some general thoughts about the insulin resistance syndrome and how it's a mixture of loss of function and intact function. And this is a rough picture of what the world of single gene insulin resistance looks like. And the first thing I'll emphasize is that the commonest group of conditions which cause insulin resistance are lipodystrophies. And those are the disorders that were so beautifully covered by Professor Ceccherini in the last session. However, there are further a group of disorders caused by primary defects with insulin signaling. So these are the primary insulin signaling defects. And insulin resistance also commonly features in a collection of disparate complex syndromes, which I'll just touch on briefly at the end. But mostly today, I want to go fairly deep into the insulin signaling defects, and in particular, those caused by the insulin receptor. I'm going to touch on lipodystrophy only to observe that much of what you would have heard in the last lecture featured a range of complications, which I like to group into three areas. First of all, there are a collection of abnormalities which are essentially exactly what I just described to you as consequences of all insulin resistance. More specific to lipodystrophy are what I refer to as the lipotoxic complications, which refers to severe fatty liver and its sequelae, severe dyslipidemia, and also in due course atherosclerosis. And then separately in lipodystrophy, those things which often bother patients most, which are the cosmetic distress and mechanical problems which arise from lack of adipose tissue. So really, we're going to be talking about the pure insulin signaling defects, and there's a lot of commonality in what I'll say between these components of lipodystrophic syndromes and what I'm going to talk about. So primary insulin signaling defects. It's just over 30 years now since the first genetic alterations in the insulin receptor were discovered. They were discovered about three years after the human gene was found. That's fairly rapid in those days where genomic technology was very primitive compared to the modern day. And when this was discovered, some syndromes which had been described clinically in the 1950s onwards fell into a pattern. And I like to view the spectrum of insulin receptoropathy this way. So recessive forms of the disease are Donahue syndrome, which used to be called leprochaunism. That's a term that we try to avoid, or Rabson-Mendenhall syndrome. But really, this is a continuum where I would estimate that receptor function is between 0 and about 10 or 15%. Type A insulin resistance is usually autosomal dominant, although it can be recessive. And this is a form of insulin resistance which only presents to clinical attention usually around the time of puberty. And I suspect that there is a contribution to losing half of receptor function to commoner forms of disease in the population, but this is much less well defined. And I just highlight the additional term which became used widely in the late 70s and early 80s, which is HAIR-AN, which simply means hyperandrogenism, insulin resistance, and acanthosis nigricans. So it is not a specific designation, and it really is a description of the features of insulin resistance, which I described to you. And the dominant forms of insulin resistance are much more common than the recessive forms, as you might expect. So Donahue syndrome, which occurs in infants with essentially no insulin receptor function, is a very unusual syndrome. So it features a severe growth impairment and failure to thrive. But actually, if you look at affected children, they have a striking mixture of impaired linear growth and impaired growth of the tissues which depend upon insulin, such as adipose tissue and muscle, and fairly gross overgrowth of other tissues, including skin, sex hormone-dependent tissues, viscera, and hair. So again, this is a really striking example of this combination of overgrowth features with undergrowth, coupled to the metabolic alterations which we know well. Rabson-Mendenhall syndrome really is best thought of as a continuation of that. There is no precise distinction of the two. Roughly speaking, Donahue syndrome is defined by those who tend to die within the first year or two of life, while in Rabson-Mendenhall syndrome, the degree of insulin resistance permits life into the second decade or beyond. But I think of this as a clinical spectrum. And here you can see the really awful acanthosis nigricans in this German published patient. Characteristic, rather coarse facial appearance with a big tongue and some other soft tissue overgrowth features, and a paucity of adipose tissue as well. There's also very striking premature carious dentition, which you can see here in this case report from India, which was seen together with some planar acanthosis nigricans and also hypertrichosis. So again, all recapitulating that point, this is a very unusual syndrome where there is a mix of excess growth and undergrowth. Nephrocalcinosis, for reasons which aren't clear, is also a very common feature of receptor defect. I might say I've never been aware of this producing any very important clinical complication, but it can sometimes be accompanied by a pattern of tubulopathy which resembles Bartter syndrome, as shown in 2 out of several case reports here. And you can see the images of striking calcification in the medulla. And this has also been seen in utero, in fact. So a very striking feature of severe receptor dysfunction. Now, the recessive forms of insulin resistance are very rare. In the UK, we probably find 2 or 3 or 4 cases per year, to give you some rough idea. Whereas type A insulin resistance, which is mostly autosomal dominant, is much more common. And where one patient is identified, in general, there will be numerous other members of the same family affected. And as you will see from this embellishment of the original description in the 1970s from the NIH, this is a list which closely resembles all the features I gave you of severe insulin resistance. Nearly always this presents in girls, usually peripubertally, often with primary amenorrhea or secondary amenorrhea with features of hyperandrogenism, possibly with symptomatic dysglycemia. And I'm just going to run you very quickly through a case report just to give you a feel for what that looks like. So this is a girl that we evaluated some years ago in Cambridge who was diagnosed originally in Italy. And her diagnostic journey took her first to a beautician when she was around 10 years old because she was troubled by facial hair growth, and then to an endocrinologist. And so as you can see, some of the early focus was on possible congenital adrenal hyperplasia, and the high level of testosterone was confirmed. But by far the most striking abnormality was the severe elevation of insulin, which I'd expect to be up to about 60 picomoles per liter, with a low blood glucose in the fasting state. It was her ovary that I showed you in some of the early slides, showing a rather classic polycystic ovarian morphology. And the glucose tolerance test too was not at all uncommon in people with insulin receptor defects. So you can see that although she was asymptomatic, she was actually quite profoundly hypoglycemic in the fasting state. But after the glucose load, she couldn't tolerate it, and so was diabetic at 120 minutes with a really vast insulin excursion, which I should expect to be 100 to 500 picomoles per liter, but which peaked here at 21,000 picomoles per liter. And this also makes the point that a fasting glucose alone is a very poor discriminator of this type of insulin resistance. So before she met us, this girl had been followed by her local physicians and treated with a variety of the agents available to try to enhance insulin sensitivity and to try to suppress her androgen production. And I'm just going to quickly show you this to illustrate that fasting hypoglycemia was quite persistent, although it gradually lessened as time went by and puberty advanced, while her fasting insulin remained spectacularly elevated. This is the normal range down here. The testosterone actually was nearly universally high, and sometimes going into the male normal range rather than the female normal range right here. And this is all absolutely characteristic of people who have insulin receptor mutations. And when we eventually saw her in Cambridge and made the genetic diagnosis of an insulin receptor mutation, we repeated her oral glucose tolerance test, which you can see in red here. And you see once again, she had this pattern of near fasting hypoglycemia, a complete inability to tolerate the glucose load with corresponding enormous hyperinsulinemia. Now, one of the things which we noticed over the years, observing many tens or hundreds of patients with insulin receptor mutations, is actually they don't look like people with obesity-related severe insulin resistance, and they don't look like people with lipodystrophy. In several respects, they are different. We routinely measure adiponectin, the fat cell-derived hormone, and while this is known to be low in common forms of insulin resistance compared to a very large number of controls, and while we find it's also low in different forms of lipodystrophy, in patients with insulin receptor problems, whether genetic or acquired, adiponectin is not only often preserved, but sometimes spectacularly increased. It's also fascinating that patients with insulin receptor problems essentially never have metabolic dyslipidemia, the high triglyceride and the low HDL cholesterol that we see in common disease and that we see in lipodystrophy. So these days, when deciding whether or not to sequence the insulin receptor gene, I always ask what the lipid profile is and ask if an adiponectin has been measured, as these have a very high predictive value for the presence of a receptor defect. So this is a different type of insulin resistance to common insulin resistance. And I think it tells us something about what that common insulin resistance is. In the same vein, this is from a study some years ago where we demonstrated also that patients with receptor mutations really don't have increased fat in their liver or increased lipogenesis in the liver, which is very distinct from patients with lipodystrophy. So I don't want to labor this point too much, but my observations of single gene insulin resistance over the years have emphasized to me that when we try to understand the common insulin resistance syndrome, we need to divide it into different parts. There are those bits of the syndrome which are due to lack of insulin action. There are many bits of the syndrome, however, which are actually overgrowth features, probably driven by compensatory hyperinsulinemia. And then there are parts of the syndrome which are driven by the failure of fat tissue to perform properly. And following on from this, patients with lipodystrophy have the full house of these, whereas patients with primary signaling defects only seem to have the top two components. Now, I said I'd talk about treatment, but in fact, we are guided by very little high quality evidence. We have a lot of clinical experience over many years. We have some case reports, we have case series, but we have essentially no trials. The important aspects of managing pure insulin resistance are to recognize that it's pure insulin resistance and to use agents that increase insulin sensitivity rather than trying to give more insulin. And that's a mistake that's most likely to be made in those presenting in pediatric age groups where type 1 diabetes is most common. There are some specialized precision therapies which have some evidence to support them, in particular recombinant human IGF-1 or recombinant human leptin, both extremely expensive and supported at present only by case series and case reports. I'm not going to cover this in detail today because we have reviewed this in the not too distant past. Suffice to say that it's clear that IGF-1 can exert some acute metabolic benefits, even in those babies with almost no insulin receptor function. But in truth, it's extremely difficult to tease out how much of the natural history of the people who are treated with IGF-1 relates to differences in the underlying mutation as opposed to the IGF-1 itself. And there's a great publication bias in that successful stories are reported and the unsuccessful ones aren't. And so in desperation, IGF-1 remains a treatment which is not uncommonly used in recessive receptoropathy. But there is really a pressing need to try to design some randomized studies which currently lack. Leptin has had a very limited experience from the NIH group have reported it exerts some benefits also in patients with receptor forms of severe insulin resistance. But once again, this is an experimental therapy at present. So insulin receptor problems are by far the commonest type of primary insulin signaling defect, but they're not the only defects or abnormalities in insulin signaling which are known. So I've told you about defects in the insulin receptor, which have been known about since 1988. There are some very rare and other scattered disorders caused by loss of function mutations in other parts of the pathway. And I'm just going to talk very briefly about short syndrome, which was fairly recently discovered to be caused by mutations in a part of the pathway just 2 steps down from the insulin receptor itself. Although they're fascinating, I'm not going to be talking about the gain of function mutations which are known in the pathway today. So short syndrome was described by geneticists. So they described what they saw, and so the acronym denotes these visible bits of dysmorphology, as you can see. And from these collections of images from the papers where the genetic defect was first discovered, you can see there is a rather characteristic facial appearance. What was less well appreciated until the genetic defects were discovered was that short syndrome is also a syndrome of severe insulin resistance in most cases. And this is 3 of the patients that we had the opportunity to study, all with defects in the same gene which is involved in formation of the PI3 kinase enzyme. Now, I'm very sorry for this very busy table. I really wanted to show short syndrome essentially to make 2 points. First of all, to plant those images of the dysmorphism in your mind so that you recognize it if you see it. And secondly, to make the point that rather fascinatingly, short syndrome produces a type of metabolic syndrome identical to those of insulin receptoropathies, but not at all like lipodystrophy, even though lipodystrophy is said to be part of short syndrome. So if I can just show you some elements of this table, you see that all the patients we studied with short syndrome, who were girls in their teens, you can see 3 across here and our proband here. None of them had poorly controlled diabetes, but all had extreme insulin resistance, as you can see from the insulin levels of the patients who had oral glucose tolerance tests. They nearly all had preserved adiponectin. These are very abnormally high levels for this degree of insulin resistance. And they also had severely elevated levels of testosterone and consistent features in most cases. But exactly like the insulin receptor patients, they had no fatty liver whatsoever, and they had no dyslipidemia. So this is a type of insulin resistance, a subtype of insulin resistance, which you get from a pure defect in insulin signaling, it seems. And again, tells us that we can't lazily think about the insulin resistance syndrome as being equal or the same across the board. Now, I also want just to touch on some acquired insulin signaling defects, which are very rare and talked about much more often than they're actually found, but they're nevertheless fascinating and also, I think, tell us lessons about common types of insulin resistance. So this is a representation of all the complicated things that insulin does inside the cell. You can see the red insulin molecules at the top about to interact with the cell surface insulin receptor. And there are two types of acquired disorder that can affect insulin signaling. First of all, anti-insulin antibodies can bind and block and interfere with insulin action. We've done a lot of work on that over the last few years, but I'm not going to talk about that further today. Or antibodies can bind the insulin receptor itself. Funnily enough, those antibodies generally activate the receptor when they're studied in the lab. But when they're present chronically in the plasma, they downregulate the receptor and produce an acute acquired form of insulin receptor signaling problem. So this is type B insulin resistance. It's called type B insulin resistant to distinguish it from the patients who didn't seem to have circulating antibodies. And these labels were produced by the team at the NIH in the 1970s. And type B insulin resistance is very rare and generally very dramatic, featuring enormous insulin requirements in people sometimes who were not diabetic before and sometimes had pre-existing diabetes. It's a highly catabolic condition with the fulminant appearance of acanthosis nigricans, often huge weight loss, and there may be some ascertainment bias, but there's a strong preponderance in the published literature in people of African origin. And generally speaking, people with type B insulin resistance have some other form of autoimmune disease, commonly lupus. So the classical pattern is severe hyperglycemia with rapidly escalating insulin requirements, often a lot of catabolism and weight loss, very severe acanthosis nigricans, acute ovarian enlargement and amenorrhea and elevated testosterone. So essentially, this is the rapid onset, severe form of polycystic ovary syndrome that I mentioned before. And these are just some pictures to illustrate from some published cases what patients look like with type B insulin resistance. So first of all, I'd say in all the photographs I've seen, they always look really miserable. That's one of the striking characteristics. And you can see this lady has some patches of acanthosis and skin tags appearing in the skin creases in her face and on her neck. And this contrasts with the appearance after effective treatment when the skin looks less dehydrated with less overgrowth. This shows the acute acanthosis that appears on the top right in a recent Polish case that we've helped out with, while in the bottom right you can see acutely enlarged ovaries, which had been normal only weeks before. Once again, this is just to make the point that the blood marker adiponectin is terrific in discriminating people with type B insulin resistance. And given how difficult the antibody assay is, I nearly always insist that adiponectin is checked when there is a clinical suspicion. Because if adiponectin is suppressed, it essentially rules out type B insulin resistance. Well, conversely, some of the patients I've seen with type B insulin resistance have the highest adiponectin levels I've ever seen. And this performs very well as a discriminating diagnostic test of receptor dysfunction. Also, because the insulin receptor is affected, if somebody doesn't have diabetes and isn't given exogenous insulin, you can show a very high insulin to C-peptide ratio, and that's because insulin is partly cleared by the insulin receptor, while C-peptide isn't. You often get features of the associated autoimmune disease. As in the genetic forms of receptor defect, liver fat is nearly always normal with no dyslipidemia, and not only adiponectin, but often SHBG and IGF-BP1 are acutely elevated. This is just to make the point that all these things which I've talked about are reversible, and tracking this patient with type B insulin resistant from a situation where they required 2,000 units of insulin a day with metformin at a time when the antibody levels were high, with an adiponectin through the roof, a very low leptin because they were emaciated and had lost lots of weight. And as the antibodies cleared spontaneously, you can see that the adiponectin fell back down into the normal range, while as the body fat came back on, the leptin restored. Precipitation on a very small sample of patient plasma to see if that plasma is able to stick to human insulin receptors. It's a semi-quantitative assay, and you can see an example of a strongly positive result here compared to the patient being tested. It takes about 2 or 3 days, and there are various diagnostic labs who offer this on a commercial basis, whose performance, I must say, is highly variable. The assay that we have used over the years is based in Cambridge and is run in a research lab, and that's the one which I understand and trust best. Now, interestingly, type B insulin resistance doesn't just cause hyperglycemia. At times in the natural history of the condition, or when the antibody titer is very low, it can also produce hypoglycemia, and that's because, as I said, antibodies actually stimulate insulin receptors. And the reason that you get insulin resistance is because as the antibody titer levels increase, you downregulate receptor. And so this is definitely one to watch out for. But even in those patients with hypoglycemia, usually their insulin levels are severely elevated. And commonly there are still features of insulin resistance, which gives the clue. So as in any disorder that is absolutely caused by an antibody, getting rid of that antibody cures the condition. There are no randomized controlled trials of the best approach to adopt, and in the literature you'll find many different examples of immunosuppressive regimen. The one which has by far the most experience is the one used by the NIH group, by Phil Gordon and Rebecca Brown at the NIH, which uses a combination of steroids together with rituximab and more non-specific immunosuppression with cyclophosphamide or azathioprine, and they produce this rather nice algorithm for management in this article. But I've seen many examples of other immunosuppressive regimens up to and including bone marrow transplantation, which have the potential to cure type B insulin resistance. Once again, this is just an illustration of how severe the condition can be at baseline, in this patient requiring 18,000 units of insulin per day, and how dramatically it can resolve over the course of a fairly short period of time with resolution of all the symptoms I described. And once again, just another picture of a patient from the NIH showing her to be happier after treatment than before, but also in this darker skin tone showing the appearance of acanthosis nigricans, which is striking both in the axillae and on some of the other mildly flexural parts of the neck, which is mostly resolved afterwards. So these are the main points I want to make about the primary forms of insulin resistance, and I'm sure, I hope there'll be some questions about that. In the last couple of slides, I simply wanted to flag up to a collection of endocrinologists interested in rare disease that insulin resistance also features in a variety of more complex genetic syndromes. And over the years, it's been my experience that geneticists, while wonderful at dysmorphism and classification based on genes, are actually very poor at understanding the implications of the features of insulin resistance. And so anybody evaluating patients with unknown or rare genetic syndrome should be alert to the meaning of acanthosis nigricans and high levels of testosterone and diabetes. And I'm certainly not going to give a comprehensive account of a collection of rare syndromes, but these include Alström syndrome, which is a particular interest in in Birmingham and Padua and elsewhere in Europe. Even rarer syndromes caused by other components of the cellular centrosome or centriole include soft syndrome and a form of primordial dwarfism pictured here. So again, I don't want you to take away too much detail here, except to say that there are some of these syndromes which feature very severe and clinically problematic insulin resistance, which is sometimes neglected at the expense of the other growth-related problems. And interestingly, this group of disorders all feature problems with a particular part of the cellular machinery, which I think is telling us something interesting and mechanistic about the way growth in adipose tissue works. There are other groups of syndromes, again, very rare, which are caused by defects in different types of DNA replication or repair. And again, these are complicated syndromes, which often feature an element of premature aging. But the degree of insulin resistance, which can be seen in any of these disorders, which include Werner's syndrome or Bloom syndrome, or this syndrome that we described recently, and another syndrome which we played a role in describing, the degree of insulin resistance can be truly extreme, and it's very important that an endocrinologist is involved in care. Many of these disorders feature impaired linear growth, and it's also my observation that when people are concentrating very hard on evaluating the growth hormone axis, that they can be somewhat willfully blind to severe defects in insulin action. So that's a caution for the future. So this more or less summarizes some of the things I've said. There are a very large number of causes of monogenic severe insulin resistance, and it tends to be the rare and recessive forms which present before puberty. In the case of the insulin signaling disorders, that's Donahue syndrome, Rabson-Mendenhall syndrome, and Short syndrome. But as I pointed out, there's a wide variety of other syndromes. Type A insulin resistance due to dominant insulin receptor defects tends to present peripubertally, and the most common reason for presentation is, if you like, features of PCOS. But I think there are also a variety of milder forms of these classical recessive conditions which may present around this time. There are many types of investigation which may be warranted depending on the syndrome and depending on whether it's lipodystrophic or not. So I shall simply leave these there to be considered. And I think the big Achilles heel in the field really is our lack of rigorously evidence-based management, simply because these conditions are so rare that there is a major organizational challenge in undertaking randomized trials. And hopefully that's one of the challenges which networks such as this will benefit as time goes by. But I'm going to wrap up there, and I'd be very happy to accept any questions.
Thank you, Robert. Yeah, it's time now for some questions. You can ask your question via the electronic hands or via the question box in the control panel. Thank you.
So just while people are gathering their thoughts, I'd re-emphasize that I think many of these syndromes are remarkably under-recognized. One of the reasons for that is that girls with severe insulin resistance tend to present, and they tend to present because of oligomenorrhea and often because of hair growth. And when a girl is diagnosed, let's say, with severe insulin resistance in her teens, it's very common then to discover that her father is said to have type 2 diabetes in midlife. And on testing, he also is discovered to have severe insulin resistance. And that makes the point that women tend to suffer more severe insulin resistance peripubertally than boys, and that's because of their natural accumulation of more body fat around that time. But it also makes the point that men don't have organs like the ovaries, which are so exquisitely upset by high levels of insulin. And it's easy to neglect the signs of acanthosis and such like in men in middle age. And commonly, in consequence, they are mistreated by people who are targeting insulin secretion rather than insulin resistance.
Pietro, you can ask a question.
Hi, this is Pietro Maffei, Padova, Italy. Hi, Robert.
Hi, Pietro.
Okay, hi.
Nice to hear you.
I would like to have your opinion about two comments. First comment is about, you showed data about the fact that the insulin resistant states may be associated with low white blood cell anemia and low platelets. So my comment is about the bone marrow. Did you have any data or any study the relationship between insulin resistant states and bone marrow failure or things or any relationship with bone marrow function? And the second question is about extreme insulin resistance and cancer, because I wonder if the blocking of the receptor in some pathway may keep high the growth factors in other pathways and maybe work as a growth factors also for cancer, ovary cancer, or other kind of cancer. So I would like to your comments about these two aspects. Thank you.
So two very good questions. So first of all, my observation about cytopenias, blood cell deficiencies, was particular for type B insulin resistance, and that is described, and I interpret that as being more of a feature of the associated autoimmune disease, often a lupus-like autoimmune disease. That's true also in some of the acquired types of lipodystrophy, which are very much driven by plasma cell abnormalities, when you can get really very floridly abnormal bone marrow as part of the plasma cell proliferation. I'm not aware of any abnormalities at all in the primary severe forms of insulin resistance, in particular the receptor forms. So I don't think the link is between insulin resistance itself and the bone marrow. The cancer point is excellent. As you know, insulin resistance epidemiologically is associated with a variety of types of common cancer. And there are several reasons why that can be. It might be related to, in some cases, to ovarian dysfunction and prolonged estrogen exposure. It might be related to abnormal steroid metabolism in adipose tissue, but I really do think that some of it is related to the sustained effects of high levels of insulin. So we know, as I said, that you get high testosterone levels and a PCOS-like syndrome in severe insulin resistance. We have 5 or 6 or 7 cases that I know of where androgen-secreting malignancies have arisen eventually in people with insulin-secreting tumors, and that doesn't seem, with insulin resistance, that doesn't seem surprising to me. I think that is a consequence of prolonged hyperplasia. I also observe in some of our infants with very severe insulin resistance, they have an appearance almost of colonic polyposis, and this is benign when biopsied, but there is exuberant proliferation of some epithelia. We just don't have the data in these rare syndromes at the moment to say that this translates into an increased risk of cancer in the long term. But personally, I'm sure it would if we had the ability to measure that. So yes, so I think high levels of insulin, which are compensatory for insulin resistance, have an adverse effect across the lifespan in risk of future cancer. I do believe that. We just don't have the full data from the monogenic disease in. I don't think you need to necessarily invoke other growth factors. I think it may be insulin interfering with IGF-1 signaling, which it can do either by acting at the IGF-1 receptor, or it can do it indirectly through changing binding proteins or changing receptor expression or changing local production of IGF-1.
Robert, there's also a question from Ingrid in the question box. Do you see the question?
I do, yes. So I have an 11-year-old with congenital generalized lipodystrophy and mild diabetes on metformin, but he does have severe steatosis. Would you start anything for that, and what? Leptin is only 11. So this is a pure lipodystrophy question, which I've avoided because of the previous excellent talk, but I think that's a very important point. So yes, I think the evidence that we have is that even people by the end of the first decade of life who have lipodystrophy, especially congenital generalized lipodystrophy, can have established bridging fibrosis in the liver. And in historical series, it said that cirrhosis and hepatocellular cancer is one of the biggest reasons for mortality in those conditions. With congenital generalized lipodystrophy, it's likely that leptin will be extremely low or absent. And in that case, I absolutely would be seeking to get leptin. And I would be aiming to treat markers such as the steatosis rather than just the diabetes. I think that's very important personally. Lipodystrophy, sorry.
Hi, Robert. Ingrid says, thank you very much for the answer. For the moment, we didn't receive any other questions by the question box or raising their hands. So
I'm always very, one of the great joys of my job is exchanging emails with people from around the world to discuss interesting or difficult cases, and I'm extremely happy to field any emails from anybody who wants to raise a question afterwards as well.
Okay, that's great to hear, Robert. Yeah, if we covered all the questions for now, yeah, maybe it's a good time to wrap it up. It's almost 4 o'clock. Do you want to say anything at the end, Robert, before we end the webinar?
Goodness, well, I think I've said far too much already. I simply think that I think networks such as the European Reference Network are tremendous things, and I expect that progress will rapidly accelerate because of the network itself and because of webinars such as this. So again, I just encourage everybody to speak to each other. And once the networks are formed, I think some of the really big outputs might be the ability to launch clinical trials in these ultra rare diseases, and that is what we need to do to take some major steps forward. So it's been a great pleasure to participate today.
I have another question from Thomas. One moment.
There's only to say a big thank you, Robert, for this fantastic talk. And as the lead of the MTG3, I just want to say this is exactly what we need, and exactly what we do was very inspiring, and the networking, and in the end doing better science and better patient care is what this is all about. And I think this was really great and very inspiring, and thank you so much for it.